Now the primary malignant neoplasia. The most frequent one is the angiosarcoma. It is common and usually originates from the free wall of the right atrium and typically with pericardial invasion. Then if we find a mass inside the right atrium, within the atrial myocardium and adherent to the wall and not to the IAS, invading other regions like the pericardium or the tricuspid annulus, there is a great possibility to be an angiosarcoma. The other one, rare, is the rhabdomyosarcoma, usually diagnosed in children or young adults. This is one example. We see here a mass attached to the right atrial wall in a quite large area. Notice that it is not adherent to the IAS, it is not mobile and has no pedicle. It has a good chance to be an angiosarcoma. Another case, large right atrial mass, notice here in this TEE, invading and adherent to the right atrial wall, without a pedicle. These are all a bad sign indicating a probability of a malignant tumor and a possibility of angiosarcoma by its characteristics. The rhabdomyosarcoma may occur in any place of the heart, may be cavitary or within the wall. This is an example inside the LA attached to the superior LA wall but not with a pedicle. There was no reason for a thrombus. Notice the hypoechogenic areas that may be due to necrosis indicating a rapid growing tumor. This is an example inside the LA in a young man. Notice the hypoechogenic areas. It was not attached to the IAS but I could not be sure where it was attached since it was large in relation to the cavity. It was not mobile. Surgery showed it to be a rhabdomyosarcoma. A period after surgery and radiotherapy, the patient's echocardiogram shows the return of the tumor. This large tumor adherent to the lateral wall of the LA, no relation to the IAS, invades the mitral annulus, seen in this short axis of the base, long axis, and subcostal views is obviously malignant and was a rhabdomyosarcoma. Metastatic cardiac tumors more frequently are from the lungs where it can also invade locally or coming through a pulmonary vein. Breast cancer, melanoma, and myocardial infiltration that may occur in lymphomas and leukemias. This is a metastatic lung cancer to the pericardium. Note that there is also pre-pericardial fat. The differential diagnosis is helped by the pericardial effusion and the round aspect of the mass with more echogenicity than the pericardial fat. This is a case of a breast cancer metastasis to the pericardial cavity. This image is a zoom from a 4-chamber view. This is the LV cavity and apex. All this is pericardial fluid and these two masses, one adherent to the visceral and the other to the parietal pericardium. Pericardial metastasis is very frequent, much more than to the myocardium. Another example of a large metastatic breast tumor to the pericardium. Notice here the pericardial fluid and the tumor. Here a short axis of the base showing a metastatic mass adherent to the visceral pericardium, in front of the aorta. Another metastatic tumor, more frequently from breast cancer. A subcostal view. The pericardial fluid and the mass here attached to the epicardium of the apex. Now just a short axis of the mass. Notice there are other masses in the pericardial cavity. This is a case of melanoma where you can see in this TEE the RVOT where there are two masses obstructing the RVOT. An interesting case. Notice this mobile mass in the LA with a pedicle not attached at the IAS but apparently coming from the right inferior pulmonary vein. ATEE demonstrated it was really coming from a pulmonary vein, so it was originating in the lung. This patient had a malignant thyroid tumor metastatic to the lung that entered a pulmonary vein and reached the LA. Another example, a large mass inside of LA, no pedicle attached to the IAS, and it seems to be coming from a pulmonary vein. TEE clearly showed the tumor to be coming to LA from the left upper pulmonary vein. This tumor was a bronchogenic carcinoma which invade a pulmonary vein. Tumors that reach the right atrium through the IVC are much more frequent. The hypernephroma is one that may invade the renal vein, then the IVC and often reach the RA. It may be mistaken as a primary atrial tumor and the patient taken to an unnecessary thoracotomy. A hepatoma can produce the same findings after invading a suprahepatic vein. Mediastinal tumors, as some lymphomas, may produce extracardiac compression or being invasive as it reaches to pericardium. In his subcostal view, an example of a large mass inside RA coming from the IVC. This is important since it identifies that it is not a mass originating in the RA. It was a hypernephroma. Another similar example, another hypernephroma, a large mass occupying almost all RA cavity but is demonstrated to come from the IVC. TEE shows an immense mass inside the RA, but the most important information, the demonstration that this mass is coming from the IVC, is not well demonstrated by TEE as it is using a transthoracic 2D subcostal view. A reminder, always check the IVC whenever you demonstrate a RA mass. If we remain with the diagnosis of a right atrial mass, this patient will have a thoracotomy and the surgeon will be disturbed to see a mass in RA but it is coming from the abdomen. Okay, he will excise the mass but will be necessary a later abdominal intervention, after complete diagnosis. However, if this mistake were not made, this tumor might be removed with an abdominal surgery, opening of the IVC and pulling out the tumor. Even the right atrial part of it may come out, though larger, it may be just coiled as a spiral, and, before all this, the diagnosis would be already made by other studies aiming at a non-cardiac origin site for this tumor. Most of the many cases we have seen came from the kidneys, hypernephromas, but also from some unusual locations, like a right femoral osteosarcoma and a leiomyosarcoma originating from a uterine vein. Another case, watch here, a tumor inside the IVC going till the RA. It is interesting to notice that it is not adherent to the vein walls. It comes as floating inside the vein. This is a hypernephroma coming from the kidney as far as the right heart cavities. TEE shows the tumor moving in and out across the tricuspid valve to the RV, as a myxoma, but it was not attached to the IAS, and transthoracic echo depicted it inside the IVC. Another case of a hypernephroma. See the mass inside of the IVC going to the RA. Once again, important lesson, look at the IVC when there is any kind of mass inside the RA. This is the case of femoral osteosarcoma, and we could see at this short axis of the epigastrium how the tumor was completely floating free inside of the IVC. No adherence to the vein walls. It just swings between the walls. See this large mass inside the RA. It was not attached to the IAS or to any wall. It was not coming through the IVC. TEE three-dimensional echo and further looking at the subcostal view showed it coming from the superior vena cava. It was a tumor of thyroid that invaded the right jugular vein and reached the SVC. This was not a cardiac or pericardial mass. We can surely show that is a pulmonary mass compressing but not invading the heart or the pericardium. Now a patient with non-Hodgkin's lymphoma. The suprasternal views show the space between the cardiac and vessel structures occupied and separated by the tumor. This is the space between the superior vena cava and the ascending aorta, usually very thin, and here a large space occupied by the tumor. The same here between the right pulmonary artery and the LA. ATEE of the same patient shows the SVC. Usually its walls are very thin, but now they are infiltrated by the tumor. The lymphoma may also present as a large extracardiac mass, posterior to the heart, invading the pericardium and becoming adherent to the ventricular wall. It is obvious we cannot look at this mass and say it is a lymphoma, only to suggest that this is maybe a lymphoma, or better yet just call this a mass. No histological diagnosis in any tumor. Another example of a lymphoma, a mass posterior to LA as seen in this long axis, but it seems to be inside LA in this apical four-chamber. We can see that it pushes in the wall of the LA but does not invades the cavity in this longitudinal axis view. Another example, no matter how incredible as it may seem, this echolucent space pushing the RA wall that may be mistaken for a pericardial cyst was really a lymphoma mass. Then, be careful, something that looks like a cyst may be a solid mass. In this case it was a real cyst. Never trust just with echo. Look at this example. The patient was referred to us for ATEE after an episode of syncope. She had an external echo with the diagnosis of a chordriatriatum. Our impression with transthoracic echo was also the same. We thought this would be the membrane of a chordriatriatum, but we were surprised to see an extracardiac mass behind the LA and pushing forward the posterior LA wall. We could detect the pulmonary veins also being pushed. What we are seeing here is not the membrane of a chordriatriatum but the posterior wall of the LA being pushed. Notice also that once knowing that this here is not the LA and hence appearing not as a solid mass but a cyst, the TEE showed it to have a solid appearance. Then, our diagnosis was of a solid extracardiac mass pushing the LA. At surgery, it was not solid but a bronchogenic mucinous cyst. It was not solid. See how we can be wrong. About 6 months later appeared another patient with the same findings. Long axis with what might be a chordriatriatum, certainly by this view not a solid mass behind the LA, but an apical four-chamber with the aspect of an external mass pushing the left atrial wall. TEE showed a solid mass with about the same texture as the other patient with bronchogenic cyst. Then we reported a large mass with a suggestive aspect of a bronchogenic cyst. Even though we always teach the contrary, we seem not to learn that echo does not make histological diagnosis. For our shame, it was a liposarcoma. Never push too much for a specific kind of tumor or be sure about mass or cyst. This tumor here is also one of those we like to say what it is. Although we cannot say if it is malignant or not, we can suggest it is a thymus tumor. The patient is a child. The short axis of the base shows a large mass, anterior, superior and lateral to the heart. At this position, it certainly is suggestive of a thymus tumor. In this case was a thymoma. Another case, anterior, superior and lateral mass to the heart in a child, suggestive of a thymus tumor. It was a thymosarcoma.